Good morning, everyone, and welcome to what is, I think, the fourth webinar that we have had on smoking and COVID since lockdown. Just going to share my screen with you. Start the slideshow. Okay, so we are this morning looking at the guidance which NCSCT have produced on remote consultations, something, a new normal that we're all having to get used to. So we are mostly going to focus on having a Q&A session this morning, and we've already got some questions that have come in ahead of the webinar, and some people who are posting questions now as I'm talking. So please put your questions in the sidebar as we move through. Just going to try and move my slides forward. Here we go. This is what we're going to do today. So I'm going to introduce the webinar. I'm Hazel. I'm Director of Policy at ASH. And then we're going to hear from Louise Ross and Yvonne Herman from the NCSCT, and then move straight into the Q&A. So if you want to ask questions, and that is the purpose of today, then have a look at the panel on the right-hand side of your screen. There is a tab which says questions. Type your questions in there and we will get through them as best we can. If we're not able to answer the questions in the time, then we will endeavour to get you an answer after the webinar. Just wanted to point you to a couple of other sources of information. So key is the guidance that we are discussing today. There's a link there, and these slides will go around after the webinar. Also encourage you to have a look at the living review, which is being led by academics at UCL, looking at the evidence between smoking and COVID. I don't think that's something that we'll talk an awful lot about today, but we have covered it in some of our other webinars. And then the Smoke Free Action Coalition Quit for COVID pages, they've got an FAQ there. There's lots of information there that you will find useful, I hope. So without further ado, I'm going to hand over to Louise Ross. So Louise and Yvonne, who we're hearing from today, really, I'm sure for many of you don't need an introduction, but I will provide an introduction to Louise anyway. So Louise was the service manager for Leicester City Stop Smoking Service for 14 years, and she was responsible for launching Leicester as the first vape-friendly stop smoking service. And since she retired in 2018, she's been working harder than ever for the NCSCT and supporting things like the Smoke Free app. And she has also been very generously one of the alternating stop smoking experts working on the Quit for COVID Twitter account. So Louise, I'm just going to hand over to you to say a few words about the guidance which NCSCT have produced.
Thank you, Hazel. It's lovely to be here today. So when lockdown happened and we realised that face-to-face consultations couldn't happen, this could have been disastrous for people's treatment programs that they were already on, and for new smokers who, who newly wanted to quit. Something had to happen very quickly to get them access to high quality treatments as they've always been able to get in touch with. So NCSCT pulled together this guidance on doing remote consultations, which obviously involve doing consultations by phone or possibly by video, and getting NRT out to people's homes so that there's no interruption to their treatment. And obviously this poses challenges, so I hope that Yvonne and I will be able to answer some questions today about how to manage the difficulties that might pose.
Brilliant, thanks Louise. And Yvonne, again, not a person who needs a lot of introduction. Yvonne is with us today to talk about the issues that relate to smoking in pregnancy, as well as her other expertise. I'm just putting a slide up here linking to the Smoke Free Action Coalition pages, which have more guidance around COVID, smoking and pregnancy. For those of you that don't know, Yvonne is a registered nurse and midwife, and she's worked in smoking cessation since 2000. She has lots of experience in many areas of tobacco control, but particular expertise in smoking in pregnancy. She's been a member of the professional working group to develop the NICE PH48 guidance, and recently co-opted pregnancy expert for the NICE Public Health Advisory Committee suite of tobacco guidance due for publication in 2021, one hopes. And she's also a trainer for the NCSCT. So Yvonne, I'll just hand over to you to say a few words about where we're at with smoking in pregnancy.
Yes, good morning everybody, it's lovely to be here. My recent experience of putting together specific things for smoking, supporting pregnant smokers to quit, led us to update the standard treatment programme that the NCSCT had put together quite a few years ago now. And we looked at the evidence that is specific to smoking and pregnancy, and where we needed to make changes and maybe make some stronger suggestions for smoking and pregnancy, because those of us who do help support pregnant smokers to quit know that it's slightly different, and you have to be a lot more flexible in the approach that you do. So we looked at what was based on the established competency of knowledge and skills that we know that do work for the evidence base, and they are still in place. But for smoking and pregnancy in particular, we looked at the sort of considerations from the latest evidence that had been put together through Nottingham University. So we put together the more emphasis on supporting partners and family members, and looking at the sort of things that we need to take into consideration, particularly about learning about their pregnancy and adding some additional questions in there as well, really. So it was a really good thing to actually update, and it fits in quite nicely with the NCSCT's remote consultations, where we still use all of those recommendations, but we add on the extra things for smoking and pregnancy to help us build that relationship with women over the phone or remotely.
Thanks, Yvonne. Right, we have left ourselves lots of time to answer the various questions that are coming in from around the country, so we've been nice and succinct with our introduction, which is excellent. So we're going to open with a question that came in before the webinar started, which I imagine is something which is taxing lots of people at the moment as we move to a kind of new way of working. So I'll start with you, Louise, and then move on to Yvonne. How would you recommend people go about building rapport with new clients, given that you won't have the cues that you would normally get in a face-to-face meeting?
Yes, I think this is one of the very overwhelming questions that people ask, and I think there's a lot that you can convey, and people may have already found this out, themselves. The way you sit, you possibly stand when you're answering questions. The lack of distractions are really important. So it sounds through your voice that you're really focused on what that person is doing. It may mean that you don't also, as you might in a face-to-face consultation, input onto your computer at the same time. That there's some nuances here that advisors will need to get to grips with, but showing in your voice and your responses to people how very interested you are in what they are saying, and sometimes you have to overdo it a little, like, oh, that is so interesting, tell me more about that, and make them really feel that this is a one-to-one conversation, that they're not just another phone call in a list of phone calls.
Thanks, Louise. Yvonne, do you have anything you'd add to that from your experience?
Yeah, I think it is going to be a lot more challenging for some people. And one of the things that really we talk about when we do the training in particular, which will still apply very much to doing your remote consultations, is making sure that you've got the right amount of time to do that consultation, and that you're following into as much as you can into a flow. You've got to sound professional, but you've got to give that friendly approach as well, because as Louise said, you've got to show that you're really, really interested in what they're saying. And although if you can do video consultations, that's great, because it gives you a little bit more emphasis on your body language, because you can be friendly, you can show you're interested, but I think if you haven't got that, then obviously ensuring that you are applying your listening skills, and that you are sort of being non-judgmental as well. And I think what does help a little bit, particularly with pregnancy, is making sure you've got some information before you start. So if you have got that ability to have some information from the referral, knowing where they are with the pregnancy, knowing if they've got any previous problems, that helps you to build a little bit more of a conversation as well, and it helps you to sort of guide it specifically to an individual need as well.
Yeah, it's a really good point, Yvonne. And we could see from the survey work that we did of local authorities that while lots of people are able to rapidly set up telephone support, a smaller number have managed to establish video conferencing. I think it'll be really interesting to see how that evolves in the future, because we also heard that people were actively looking at how they could sort of integrate some of these different video platforms. Sort of thinking about the different environment that we're now in, where more people are at home with the family, a really interesting question about sort of so how do we talk to the wider family or household using the fact that everyone's at home to try and engage other smokers in the household, and any suggestions on how to do this or examples that you could point to. I think that's an interesting point, that we are counselling people and perhaps in a different context right now. Yvonne, perhaps if we start with you and then go to Louise.
Yeah, and actually, as we know, whether they're pregnant or they're not, partners and family members can sometimes be key to success. And I think from the latest evidence that actually came out, it showed it's the #1 barrier for some people to quit, and yet it's the #1 facilitator as well. So if you can get families on board, I think that's that you're halfway there as well, really. Obviously, I don't know quite whether there's service provision for you to support pregnant smokers alongside family members, but obviously that is something that I think is highly recommended. So if you can engage before you even start the conversations, if it's possible for you to say, if your partner is interested and would like some support, that you could, particularly if you're doing a video conferencing call with them support, I think that would be ideal for you to maybe do it together if that is possible. Obviously family, if they've got the children, that could come into play as well and cause a few distractions. So that needs to be taken into account. But it's certainly worth offering that support to them, as they're so important to success.
Yes, thanks, Yvonne. Louise.
Yes, I think it's important to note that we often see accidental quitting amongst the family members. So they may not be signing up to the whole idea of quitting when the primary contact first joins the service. But if they're aware of what's going on, particularly if they've always shunned the idea of quitting, but maybe the person who's come for help is using a vape, and the other person thinks that they might like to have a go at it. It may be that a couple of weeks in, you've got more family members have joined in, and clearly families are closer together at the moment. They're talking more. There may well be some extra interest among family members who wouldn't have considered it in the first place.
Sort of following on that, sort of we're in a different kind of environment. I've got a question sort of looking at that issue that you raised about people being more motivated, Louise, in a slightly different way. So Alan has asked us a question. So because of the stress of COVID, I find patients find it more difficult to quit, especially if they're in a rural area and can't leave the house. Advice is the end of that question. I think if we look at the data that we're seeing in work we're doing with YouGov on their COVID tracker, you can definitely see there are a proportion of smokers that are highly motivated and taking action around their smoking because of COVID. But equally, there's a group of people saying they're smoking more, that they're stockpiling tobacco, that those who've already quit, a small proportion saying they might be more likely to relapse. So you can see how the kind of COVID lockdown situation might be playing both ways. Do you have any reflections on that, Louise?
Yes. I think for some smokers, there will always be a search for a reason not to actually stop right now. But if we explain that smoking, it increases the risk of acute respiratory infections, that if they get infections, they're likely to last longer and be more serious. But this is a really, really powerful reason to stop right now. And COVID, we hope, will be over eventually, but the long-term risks of smoking remain. So the cancers, the heart disease, the respiratory diseases, and this is such a good time to do it. And I think conveying that urgency at the time of COVID can help. Now, if somebody is in a rural area and unable to maybe get to their pharmacy or get to a vape shop, there are postal services, but having the advisor on the end of the phone and able to speak to them without leaving the house can be a bonus rather than a deterrent. That's what I would say.
Thanks, Louise. And Yvonne, I've got a sort of pregnancy-related follow-up to that. So I've got Jackie here saying some of the pregnant clients are very stressed and under the impression they are not allowed to leave the house even. What can we tell them to reassure them that they do not need to shield unless underlying conditions present? And I guess that sort of links to the issue around, you know, pregnant smokers also facing additional stresses and communicating with them in this difficult time.
Yeah, well, I think there has definitely been some challenging questions on COVID and pregnancy. But what we know is, and from your previous webinars, you know, it's made very clear that although, you know, pregnant women are at risk of getting coronavirus, you know, they are no more likely to get it than other smokers as well. But I think it's important to ensure that we ask the question, is there anything that's worrying you, you know, because that immediately helps you to find out what is their worries, and you can put their mind at rest. And I think that's important, that we give the right information. They need to go for antenatal appointments. Midwives are hugely important, you know, at raising these questions as well with women. And, you know, I know that a lot of areas are working with their midwives to make sure they know the right. And there's been some great documents out there to give midwives the information that they need, but we have to be absolutely, you know, sure when we're saying to women it's an absolute priority for them to be smoke free, because that is a huge worry, you know, for the outcome of pregnancy as to whether it's going to be, you know, a good outcome. So I think although we need to acknowledge, and I think that's a part of the building rapport, is acknowledging their worries, being empathetic to what they're saying to you, but actually making sure what we know is, and giving them the right information, following the protocols and guidelines that have been issued as well.
I think this interaction with mental health is really interesting, and there have been a couple of specific questions here about sort of whether guidance be adapted for mental health settings. You know, it seems likely that you know, the current environment for various reasons will have an impact on the nation's collective mental health, and obviously that has a strong relationship to mental health status, has a strong relationship to smoking and relapse to smoking. Louise, is there anything that we should be thinking about, you know, picking up on what Yvonne was saying about asking people, you know, are there things that they're worried about? You know, are there things that we should be sort of flexing in our delivery of support to people to reflect the fact that, you know, people are may well be in pretty challenging circumstances right now?
Yes, I think it's something that we really need to be conscious of, that some people are stuck in, you know, high-rise flats with small children maybe, or subject to domestic violence, that there will be a lot of very, very difficult situations that people are living in. But the idea of stopping smoking is still a high priority in terms of long-term health, money, and so on. I think there are ways of acknowledging people's difficulties without, I suppose, colluding with the idea that they need to keep on smoking to manage their stress. You know, the idea that stopping smoking actually, you know, eventually makes you feel much less stressed, because you're not constantly craving a cigarette and having to get out and buy more.
So thinking about sort of moving on to some of the logistical challenges of not having our traditional services, access to NRT has been a bit of a challenge, I think, in many areas. And our previous webinar on, you know, using different practice examples, we had some discussion there about different ways of getting NRT to people. So we've got a specific question here that relates to the delivery of NRT, but I think we've had quite a few questions around this. So if we could perhaps talk about what some of the options are, Louise. The specific question here is, how are services dealing with consent forms when doing telephone-only advice and remote deliveries of NRT, consent to the treatment programme and consent to data holding under GDPR? Sorry, that's a slightly broader question about consent, but then I think it would be useful to move on to, you know, because we're a distance, how are we getting NRT to people?
Right. I mean, from a consent point of view, I think, you know, because we're in difficult times, we have to make pragmatic decisions about how we do that. So asking verbally for consent and recording that in your patient management system will have to be the only way of doing it. As far as getting NRT to people, I would hope that local authorities are being as helpful as possible to the Stop Smoking services and helping to problem solve rather than putting a lot of rules in place. And we know, I mean, you and I were having a conversation earlier about volunteers going out with NRT and posting it through people's doors, advisors doing that. We have to be pragmatic about this and understand that the postal service may be delayed. We've heard of even simple letters taking up to 10 days to be delivered. If delivering is the best way of doing it, then that should be the way it's done, because we don't want people to relapse because their treatment program has been interrupted. We want people to be as successful as possible, and that message has to be imparted to the local authorities who are perhaps making decisions that aren't as helpful as they could be to advisors who are trying their best to get clients to quit.
And I would point you to our last webinar where we talked about this, but also the briefing that PHE and ASH put together with examples of different practices from around the country, which shows lots of different ways of getting NRT to people right now. We'll circulate that with the recording from this webinar afterwards. Lots of questions as well on the fact that we no longer have carbon monoxide screening, and how do we cope with that? So questions about how do we motivate people in the absence of carbon monoxide screening? Are there alternatives that we could be using? Kate here saying, CO quit, how are we to overcome this and keep clients motivated when many of the sessions would usually revolve around this measure as a central point? Yvonne, perhaps if we start with you, because carbon monoxide screening has obviously been a very important part of the model for pregnant women for some time.
Yes, it absolutely has, and I've got to say I can see why it is difficult. It has definitely helped you to start conversations, carry on conversations, give information and get feedback from women, and to motivate them to quit and to remain quit. So it is definitely a challenge. I think the only thing I would say is that we've got to be really positive with how we speak to women, about really making sure that we praise them and that we are giving them as much encouragement as possible. And that's not just about the practitioner who's supplying the support, but it's about all the other maternity care providers, in particular for pregnant women, making sure people are recognising and that it is documented as much as possible that they have quit and where they are with a quit. I think one thing I would say is to be very clear with how you're asking the question. So not just saying, are you still smoking today? It's about, have you had not one single puff on a cigarette today, yesterday, or when was the last time as well? So when you are validating, and although it's self-reported, that you're being very clear that you know where they are with their quit journey. So I acknowledge, I think it is tough not having carbon monoxide testing, but I think it is about your language and it's about your responses that you give to women as well, and ensuring they know how important it is what they've done and the benefits that they've got from quitting as well, and making sure you're linking it to the amount of oxygen and the baby's growth. So being quite specific with making sure they understand about carbon monoxide and how quickly it's got out of the system. But I do acknowledge, I think not being able to CO validate or to use it as part of the programme is probably one of the main challenges.
Louise, thinking about the rest of our smokers as well as our pregnant women.
Yes,
obviously carbon monoxide screening is the gold standard.
Yeah.
This came up with the team of experts that I support as part of the Smoke-Free app. You know, they text their users, and the users text back, and so obviously CO monitoring isn't an option. And I suggested that they actually can describe what the person would be seeing on the chart if they were actually doing a carbon monoxide test face to face. And a lot of smokers who've gone through the Stop Smoking services before will know what that chart looks like. So, you know, you can say, you know, how long is it since you had even a puff on a cigarette? And they say, you know, 5 days. And, you know, if you know that they were smoking a pack a day before that, you say, well, you know, you would definitely have been in the red area if you were still smoking. And now I'm absolutely sure that if we were doing a test right now, you would be right down there in the green in a non-smokers you know, band, and just describe what they would see. So you can still get the motivation aspect of it without actually having them in front of you.
And I think I'd also suggest, leading on from that, sorry to interrupt, which is a great point actually, it is about giving them something visual to look at, you know, and hopefully if there are some local resources that when you start the programme, you can make sure they've got a sort of visual chart that they could see themselves and say, if you look at the chart now, you know, this is what we'd expect you to be at, and that means your baby is getting all the oxygen it needs to grow and develop as it should do, or this is the amount of oxygen you're getting, so your body is now recovering. So yeah, I think something visual is really good if you can get that to talk them through it.
Well, a shout out, I think, if anybody has a sort of visual aid in the way that Louise and Yvonne are describing, and they want to share it with us so we can share it more widely, please do send it through. I think that kind of practical tool sounds really useful.
And it's about painting a picture in words as well. So, you know, if you actually say additionally, and I'm sure many advisors do this anyway, you know, what the carbon monoxide actually does, and emphasising that it makes your blood thicker and stickier and more likely to clot. So you're painting a picture with words.
So kind of picking up on this as well, sort of finding new ways to communicate with people. A question here from Stephen. So he's asking if there are examples, but I wonder if you could also offer your reflections if you're not sure about examples of good practice in terms of providing more reactive remote support between formal telephone consultations, such as via WhatsApp or social media, either one-to-one or in groups by specialist advisors or peer support. Really interesting ideas, I think, in that question. Louise, I don't know if you've got, I mean, I guess the app would be one example that already existed of the Smoke-Free app, of how you can provide sort of interactive responses.
Absolutely. And we know that, I mean, I'll say a bit more about the app in a minute, which is referenced in the NCSCT remote working guidance. Oh, I've lost my train of thought now. We know that a number of stop smoking services are suggesting to people that, as well as using the advisor through the SSS, that they use the app too, because what the Smoke-Free app can offer is on-demand questions with an advisor at any time. So there are experts are available from 6 AM till midnight, and we've just added 2 till 4 in the morning, and there are some hours covered at weekends as well. And it's very interesting how emotional smokers can be at you know, those, you know, in the dark hours of the night or the early hours of the morning, about, you know, having had a row or something like that and really being tempted to have a cigarette. So they in a way contact the expert on duty to be talked down off the ledge, so to speak. And we find that really useful as an adjunct to what they're getting from a stop smoking service. So if you want to see it, you look on the App Store, and it's the Smoke-Free app with a green heart. There are lots of features there if you use the free version, but for the pro version, which some local authorities have actually bought in for their smokers, you can get the on-demand advice from the expert team.
Thanks, Louise. We've got a question about how to sort of understand how much NRT to give people. So Sarah here is saying, I use CO readings to form part of a decision to calculate NRT level to give, in particular with low-level smokers. Does anybody else use it in this way, or do they stick to the over 10 cigs is high patch? So she's worried that about how to calculate how much NRT to give people without the carbon monoxide screening. Louise, do you have any thoughts about that?
Yes, I would say that using a carbon monoxide level to determine how much NRT to use could be misleading, because if they hadn't, say they're feeling a little bit unwell anyway, had a bit of a cough, had decided to cut back on their cigarettes just for a few days, you get a lower level of CO reading than you would if they'd just had a couple of cigarettes that day. So I think talking to them about their regular use would be the most likely successful way to choose how much NRT to use. And of course, it's something that can be titrated up or down. If they're feeling by the second session that you have that they're using a bit too much, then you can bring it down, and equally you can add a product or make it a bit stronger if it's really not controlling breakthrough urges to smoke by the second week. I don't know, what would you say, Yvonne?
Yeah, they are good points. I think the carbon monoxide testing is one part of assessing addiction, and which helps you to get a picture of what that person will need. So it is helpful, but it's not the only thing. I mean, time to first cigarette is a really good way to assess people's addiction, and as well as asking how many they smoke, but also asking if they've made any changes recently as well. Because as Louise said, actually a carbon monoxide test doesn't, you have to, before they do a carbon monoxide reading, you are asking them, well, when was your last cigarette? And some people may not have even had one the day that you're actually seeing them, because they're just assuming they're going to quit straight away. So looking at their previous history as well, checking about if they've quit before, finding out what they actually like and what did they find they tolerated well or they didn't as well. So although CO tests are important, I still think it's really important. I would never ever use that as a one-off. It's about getting a bit of a story about their smoking habits, and as Louise said, you can, I mean, I always think it's important not to give them too much to start with. You're almost testing what they like and what works for them as well, really. So actually, no, it's really important not to give too much nicotine replacement therapy, as in the amount that they're giving them rather than the strength. It's better not to set them up to fail as well. So it's really important that we use combination therapy if possible, so we make sure that they are having that intermittent nicotine replacement therapy, as well as say a patch that is giving them a steady flow of it as well, really. And you can alter it, quite often, you change what works for them week on week. Even with the carbon monoxide test, sometimes you never quite get it right, so the following week you're changing what the products and the strength that they actually need.
Thanks. Sort of sticking on kind of nicotine, there's a question about whether there'll be any formal guidance published re the e-cigarette use for COVID-19 patients. I should think that's unlikely, but I wondered if people had reflections about how we might be using e-cigarettes at this time, and talking about e-cigarettes with clients. I don't know if you would really change what you were saying at this time, or whether it would be the same advice you would always provide, Louise.
I think the big challenge at the moment, and I was talking to a colleague or previous colleague yesterday about this, but she said it's really hard trying to explain to somebody over the phone how to actually use their vape. And I can see that is a bit of a challenge, because really it's a person-to-person, face-to-face thing, where you demonstrate the use of a vape. So without that, I mean, it's good news that non-essential shops will be open in about 3 weeks' time. So vape shops will be open again, and I feel that it should have been open before now anyway, because it's such a popular way of stopping smoking. But there are a number of forums and demonstrations on YouTube that people can be directed to. I think that as an additional thing, when you can't have that face-to-face interaction, is really important, because we don't want people to just drop the idea of using a vape just because it's much harder than opening a pack of patches or lighting up a cigarette. It has to be a viable alternative.
Yvonne, would you have anything you'd add to that?
I think, yeah, I think that's a really good point about online information. And actually, YouTube has got some really good videos showing clips showing how to use it, and you know what they've found when they've used it. And that is actually the NCSET put that together with the New Nicotine Alliance, and that is really good. And I quite often used to use that as an example and say to them, have a little look, see what you think, and that just gives you a little bit more information about how they felt about using it and how they started. But I think the e-cigarette thing particularly, if we're talking about people in the home, it's a great way of reducing that exposure to secondhand smoke for children, and also partners if maybe they aren't smoking themselves, or if the partner doesn't want to quit, but we can get across to them, well, you know, maybe it's not ready for you to quit just yet, but actually if you could switch to e-cigarettes, that would definitely prevent, if people are being enforced to be at home a lot more than they were, then I think it's a great way of chatting to them about maybe switching, and who knows, it's quite often just something that they go from one and then thinking about quitting after that. So I think e-cigarettes are a great way of reducing exposure for children and other family members as well. So I'd always try and bring that into the chat with the people, you know, when you do your consultation, to find out, you know, because it is, you know, it has been reported that it is more of an issue for being exposed to secondhand smoke in the home.
See, now you mentioning the wider family, there was a question about health visiting. I'm trying to find it. Oh, it's a comment, but we can discuss it. So health visitors give family approach support in terms of health promotion, which includes smoking cessation. We are delivering routine VBA for all mandated contacts. Working within a multi-agency approach is essential. I think that's a really interesting point there about our allied professionals out there who might actually be having some face-to-face contact with families. Health visiting is certainly one example, and I guess increasingly people will be going back into their GPs as well. I mean, what relationships would we like to be seeing, I guess, between, say, for example, you know, maternity quit support or stop smoking services and those other professional groups out there, and getting the message to them? Yvonne, perhaps I'll start with you.
They are hugely important, absolutely. The wider we can get the correct messages out there, I mean, this is the importance of making sure that these maternity care providers, whether they're the health visitors, the family nurse partnerships, are strengthening families teams, looking after vulnerable families as well. It's about getting their knowledge out there to give them the confidence and the skills to have them conversations. And obviously, hopefully, a lot of people have already had that type of training. But I think they are key. And family nurse partnerships, I know I've done a lot of training with them, and they have found it so helpful. And I think they are looking about reducing risks, particularly in the home. And if we can all be saying the same thing and being consistent with our messages, I think all the multi-agency, we're all in it together, and I think that's been my mantra for a long time. It's not just about midwives supporting families, but the wider community as well, because, you know, they're pregnant for 9 months of the year. The rest of the time they're general, you know, populations. So we've got to be getting the messages across to them as much as we can. So yeah, I totally think that's a really good point. I think they've got such an important role to play.
Louise, other professional groups other than health visiting out there who might be talking to our smokers?
Yes, I think any frontline worker who has an opportunity to do a very brief advice intervention really should take the opportunity at the moment. And we've heard little bits about people being unsure about how to approach this because they've heard that smoking might be a protective factor. I think it's really important that we get that message across, that smoking is not a protective factor. And Nick Hopkinson has done a very powerful podcast on the Quit for COVID, the Today is the Day website, you know, making that point exactly. We know that people are talking about the possibility of nicotine itself being a protective. It's speculative. We don't know for sure. It's being tested, but certainly the idea that smoking might be protective has to be challenged amongst frontline staff who could give the wrong message about smokers quitting right now.
Well, I think that's you're right there, Louise. And if there is if the hypothesis that nicotine could offer some protective factor around COVID were to be found to be true, which is still a long way off being demonstrated, we know that smoking is lethal for a whole range of different reasons and causes a whole range of health complications. So I think the message to smokers is quit, use nicotine to quit. We know it will make it more successful, and if there is any potential protective factor, it's going to be in the nicotine, not this lethal tobacco smoke.
Absolutely.
Right, so I've got some sort of logistical questions. I don't let's see if you know the answers to any of these. I certainly don't. So we've got a question here from I think he describes himself as an overqualified smoking cessation advisor, but I think he just means a qualified smoking cessation advisor. I would like to do remote consultations, but I work as a locum pharmacist for places such as Asda, and their systems do not allow for Skype or WhatsApp. How do I get around this? I don't know.
Yeah,
either of you?
That is a tricky one, and I've had conversations with pharmacists who've said that they find it really difficult. They haven't got the allocated time to do it, and I think that is absolutely crucial. That if the pharmacy is expecting to be able to do successful stop smoking in treatment episodes, then the time to actually deliver that well has to be negotiated with the branch or the owner, whoever is making those sort of decisions, because you can't just do it on the fly while you're seeing other patients.
Actually, I've got a follow-up here as well. Question/request. Would it be possible for you/us to work with PHE/government to facilitate and enable pharmacies to conduct smoking cessation clinics via telephone and video with delivery of items? Locally in Birmingham, our pharmacies were told that their smoking cessation clinic should stop, and the commissioning for this had stopped at the start of COVID. This means reduced access to smoking cessation, plus smoking cessation support being done by GPs and primary care teams who are less experienced and uncertain of how to do it. People are not being supported as well as they could be. I mean, there's quite a few questions actually about delivering through pharmacy and the challenges of that right now. I don't know if you've got anything you would add, Yvonne or Louise, but perhaps it's something we should take away and think about a little further.
Yeah, I think so. I think it's a question for commissioners, isn't it, as well, really, as to where they are with this and how they've made them decisions, and are they valid decisions, and this could be going on for quite a long time, and it's really unfair not to have support out there for smokers who do want to quit, and we could be missing an opportunity if we're not careful, because this has definitely prompted a lot of people to stop smoking, and they do need support, because otherwise the chances are they might relapse back to it quite quickly.
So I think we could take on that we will have a look at, see whether there's any further advice which PHE or anyone else could offer in relation to the pharmacy delivery, which I think is is clearly a challenge. Another question about sort of pragmatic question. What do you think would be the best video call forum, and how do you deal with privacy and availability, as the phones we're using now don't have that function, so we'd have to use our own? Interesting.
It is recommended not to use your own personal phone, obviously. So if you haven't got a work phone, like a mobile phone, then obviously I wouldn't be recommending using your own personal phone. I mean, we've talked about the advantage of trying to do a video calling, whether it's FaceTime, but obviously at the end of the day they have to have the right phone to do that. So I think it's about what facilities you've got. One thing I would say more than anything is about when you are doing the consultations, you've got to have that quiet area to do it in as well. So whether you do it by phone call or by video call, there's lots of tips in that guidance that sort of suggest how you should be doing it as well, really. So again, I think I personally would say don't use your own phone, because you've got to be very careful about confidentiality and also protecting yourself as well, and giving away any information that you shouldn't be. but you do need to make sure the logistics are right and that you have got the right facilities to do it, whether it be that you're using, you know, that you can book out an office for the day, or whether you are working from home, because we've also got to be very careful about how we work, you know, with social distancing as well.
I think it's a matter of, sorry.
Go ahead.
I think it's a matter of you know, speaking to your IT department and taking advice from them, because you know, the servers are different, the technology will be different. I remember on one of your other webinars, though, Hazel, that Zahira Chatra from Leicestershire suggested using Microsoft 365 for remote contact rather than Skype. Now, I haven't done that, but that was a recommendation from her, so might be worth making a note of that for people
remembered, Louise,
listening in.
And for those of you who've asked, because we've mentioned the previous webinars a few times, we will circulate the links to those webinars after this recording. I will also circulate, as I've just been sent it by Joanne Fuller, the video that they use, which Totally Wicked produced, to provide people with advice on how to use e-cigarettes, following your comment, Louise, about the challenges of that. So we've got something we can circulate that people could use. I'm going to ask one more question about the kind of current remote working, and then we've had quite a few questions which I will try to sift through about what it might mean if we return to face-to-face support in the nearish future. And we might spend the last sort of 5 minutes thinking about a possible face-to-face future. We've got a comment from Wolverhampton saying that they've, well, actually they're not commenting on whether they've seen an increase or decrease in referrals. But wondering whether other areas have seen an increase or a decrease in referrals. And I guess my question from that for the both of you would be, from the survey work that Ash has done, we can see that sort of something around 20% of local authorities are reporting that they've seen an increase in footfall since lockdown, and then others are not reporting that. You know, what do you think could help make the difference in terms of getting people through the virtual door, so to speak, at this time? You know, given there is a division, I think, between those services who have seen an increase and those who haven't.
What I'm hearing is that there seems to be more enthusiasm amongst smokers who think that they're really going to do it this time, but there are still an awful lot of people who are not contacting. And I think partly that's because they're not having the same number of primary care consultations. They're not going to their GP. We know GPs are you know, much quieter at the moment because people just aren't rocking up as they used to be. I think GPs could really fill in a gap here by communicating, you know, by text, for instance, to remind people that their stop smoking service is still up and running, that they might be doing things differently, but there is still a service going on.
Thanks, Louise. I think that would definitely chime with the experience. Some authorities have done those text messaging and have seen a real sort of spike in interest. Yvonne, would you have anything to add, maybe particular to the kind of pregnancy space? I'm sure that we had some stuff through from people who were saying they'd seen their pregnancy referrals sort of fall off a cliff, which is concerning.
It is very. Obviously, communication is massively important with the frontline workers. So even if you've got the stop smoking practitioners, the smoking and pregnancy practitioners, it is about maintaining contact with the frontline support workers, whether it be by, you know, putting messages on their intranet systems. I know that's what they were looking at doing in Shropshire, to make sure that they still, although we've actually had to stop the face-to-face training, so that always motivates and keeps people going, the questions are still kept on board, so that they should be following up. And I think the important thing is, I don't know what it's like for everybody else, but I know in Telford and Wrekin, they've got a very good system of where it is opt-out, obviously, but maintaining that. And I think it's challenging as well. It's challenging the midwives if they're not referring people. I think it's really important that, you know, they understand how important it is. But obviously every area is different, and every area seems to work in a different way. Some people have better, easier technology to refer than others. Others are still doing it by telephone calls, and unfortunately some of them have been taken off to do other things as well. So it may be inevitable that hasn't happened, but it's massively important it doesn't become part of what happens for the future as well, really.
Well, I think that leads us in quite nicely, Yvonne, to thinking about, we've been through this really sort of emergency few months where we've had to have a screeching handbrake turn in how we deliver. And now it's about, right, what do we consolidate for the next few months? What do we make sure that we need to get back working that maybe has fallen to the wayside? What do we need to be thinking about as we might move back into a face-to-face support phase? I don't think we have any indication that the advice around providing face-to-face support will be changing in the near future. I think it seems likely that the advice will continue to be for at least for a while, that support be delivered remotely. That might be slightly different for some pregnant women who might get some support, I suppose, within maternity settings. But just thinking about what it might mean when we do return to face-to-face, if we do so ahead of a vaccine, for example. I've got a particular question here about whether either of you have any reflections on whether there'll be a requirement for PPE for frontline staff who are delivering smoking cessation. I guess maybe to you first, Yvonne, with your midwifery hat.
Well, I think there are ways around this once the lockdown has been eased, and obviously that is happening now that we are over the peak for now anyway. And I think we do need to start thinking about being a bit more innovative. Now, we've obviously a lot of areas do home visits because that's part and parcel of what has always been the bread and butter of what we do, because we know it works well. But I think what also works well, if we can get that face-to-face, is maybe making sure we link in with the midwives when they're doing their community work. So if they've got antenatal clinics in particular key areas, and about making sure that you look at the areas of need. So doing some better planning as well. So it may be, obviously there seems to be so much contradiction with whether we should be wearing masks or not, but obviously it's following local guidance and local protocols as well, really. But if we can get a face-to-face, so you can get much more of a better clarification of information and giving some better guidance on it, I think it might be just about getting out there and maybe working more closely in partnership with the people who are delivering that frontline antenatal care, so that you can link in with them a little bit. And I think that definitely helps then the midwives to make sure that they're still on top of the game and they're understanding why they're doing what they're doing and how important it is, and how they can build it into their own practice as well.
Thanks, Yvonne. Louise, I don't know, it's a bit of an unfair question, really. Do you have any thoughts on PPE?
Well, I think it's forced on the services an opportunity of doing things differently, being more flexible, and this could open up opportunities to reach people who wouldn't have come to the services if they had to turn up at a clinic at a set time. For telephone consultations, you still want that kind of set time idea, but it would make it easier for people who dismiss the idea of turning up at a clinic to actually have a treatment with a specialist. So I think that's something that the services will have tried, they will have learned from and gained experience of, and be able to build into usual care for the future. Some people will want to be seen face to face. What it makes me think of is, that different premises might be needed. That certainly my team used to sometimes work out of tiniest little cupboards at Age Concern, something like that, Age UK rather. That there will have to be rooms where there is a bit more space, so that you can keep a certain distance. It may be a while before CO monitoring comes back, even if you're sitting in the same room as somebody. That will be about assessing risk. I think there's an awful lot of consideration will need to go into that, but that's a given, really, isn't it?
Absolutely. So thinking about sort of things we need to think about now as well as potentially in the future. We have discussed this on a previous webinar as well, and we'll, again, when we circulate the recordings, and we'll circulate some of the other documents that went with that. So we're asking questions about distractions and tips that people can use, given that lots of what services would usually suggest might not be quite appropriate for a in a kind of global pandemic lockdown context. Any good tips of things people can do to distract themselves that are COVID friendly? Start with Louise and then move on to Yvonne, and then we've got one last question before we close.
Okay. Well, I think the idea of distracting yourself has been everybody's priority, hasn't it, during COVID? You know, people that are getting bored or frustrated have had to find all sorts of ways to pass the time.
Preferably not ones that involve alcohol.
Yes, that's right. Yeah. You know, the tidying of cupboards, the clearing out of clothes that you don't want anymore, you know, going for walks and that sort of thing, phoning friends, doing a Zoom call, doing puzzles. They're all the same things that we would suggest to people who need to distract themselves just while that urge to smoke has hit. So that it gets them through the next, you know, 5-10 minutes or so, longer if necessary, so they don't light up that cigarette.
Yeah, and I think, yeah, so, oh, sorry, I butted in a bit quick.
Ahead.
Yeah, I mean, it's still about pulling on what has worked for them so far as well. You know, how have you been coping since you've, you know, been in the lockdown? What have you, you know, what have you managed to do? And what have you, because quite often, I don't know about everybody else, but I've taken up new skills that I hadn't had before, you know. So finding out what they're doing now, are they enjoying it? You know, have they taken something up they hadn't done before that they can use as a distraction? Because obviously, you know, we know social isolation has been a real barrier for some women when they need to take time out if they've got children, because, you know, we have to acknowledge that, and not everybody's got gardens, as we all know. That's a real problem for some families as well, really. But just trying to get them to think of a menu of options of things that they've tried already, or things that they've done when they've been feeling fed up and a bit low, and something they think, do you think that's something that you could adapt, you know, when you are feeling like you need an urge to smoke? So it's just about trying to have that conversation with them, which is a bit of a two-way feedback thing. So asking them the question and asking them what's worked for them so far, and then just acknowledging when they are making them changes, because, you know, we need to acknowledge that it's a really difficult time for them.
Thank you. So this is my last question. My last question on the webinar that we did with the local authorities who were all trying new things in light of COVID and the need for social distancing was, what was the one thing that they would want to hold on to once all this has passed us? And I want to slightly change that question to both of you. And ask you, I think this is a time when we can see that from all the different things that people are trying to do, that it's a real opportunity for innovation and to try something that you've not tried before and see if it works within your service. What's the one thing that you would say to people it would be a really good idea to give this a go right now, with a view to perhaps it becoming a more established part of your service in the future? So I'll start with you, Yvonne, and then we'll end with Louise.
Oh, well, that's a difficult one, isn't it? That's really difficult.
Oh, sorry. What do you think people should really give a go right now?
Right. Well, obviously, I'm talking from my perspective as a trainer, and I took up this new post only earlier this year, and of course everything came to a standstill in the middle of March, and of course a lot of people got taken off to do other things, so their priorities changed, but things you can tell are definitely starting to ease already. But what it's made me think about is I need to be braver and a bit more innovative in how I get information out to our key health professionals and the frontline workers. So I'm now looking at doing some training online, but not because I don't think sometimes when you're training people, you have to be cajoling, you have to motivate, you know, sometimes you have to lead by example, and you can't always do that by just saying do an online training. Sometimes you have to be there and say, look, you know, this is what we found, and you've got time to actually share information. So I am looking at doing some sort of online training, but interactive online. So it's like a webinar type thing, a little bit like we're doing now, but actually doing it as almost a Zoom sort of thing, you know, or you know, one of the webinars we've got. So personally as a trainer, then I think I definitely think, and for the future, because trying to get time for, you know, because one of the battles we always have is trying to get frontline health professionals and particularly maternity care providers, they have so many competing training, is to try and get them to do something that's not going to take up so much of their time.
Yeah, and getting people to try do it a bit differently. Now is the time to do it, because it's not like you've got another choice. You're not going to all get them all in a room.
Exactly.
Louise, what do you think people should give a go right now with a view that they might keep it longer term?
Well, I'd strongly recommend using the Smoke-Free app as an adjunct to their regular stop smoking services, because it has the potential to bring in people who who tried and didn't make it with the stop smoking services. It just gives that extra bit of support that is digital based, and we know that digital is underexploited in terms of helping people stop smoking. It has big potential.
Fantastic. Thanks, both of you. That has been such an interesting hour, and we've got lots of people commenting they found it useful. We'll circulate a whole load of information after the webinar, including this recording and previous recordings. Many thanks to all the questions that have been asked. I'm sorry that we haven't got to all of them, particularly those of you from other countries who'd asked specific questions. I'm afraid I have focused rather on the UK context. A round of applause from me to Louise and Yvonne. Incredibly difficult to answer a barrage of questions for 50 minutes.
It was great fun.
Lie down now.
Yeah, it was
good. Please do. We'll circulate details of future webinars. Please do sign up. If you don't already get updates from the Smoke-Free Action Coalition, then you can sign up to those from admin at smokefreeaction.org.uk. And hope to see you on future webinars. Thank you to Yvonne and Louise.
Thank you.